So I've got several videos to play for you today. There's lots of good stuff out there. So you know that ART is antiretroviral therapy. AIDS, or the treatment of HIV, love abbreviations, and they use it for everything. Every drug has one. All their different protocols have them. So when you talk about antiretrovirals, that's what these drugs are called. So ARV you will see commonly. You know there's no cure. There's lots of protection and prevention that people can do to decrease their transmission. The drugs will protect their immune system. They can strengthen it. They don't strengthen the immune system so much as they allow the immune system to recover. And they reduce transmission, which is huge. So the big cells that are affected are which ones?
T4 or CD4?
CD4, but CD4 is what?
T helper.
B cells.
Well, I can't hear your... So it's a glycoprotein complex on cell membranes, right? So most of your T helper cells have them. A lot of your white blood cell different population have them as well. So they are a glycoprotein antigen that allows them to recognize self or non-self. Well, the viruses got really good. They can look like self. So the immune system doesn't attack them. Okay. So what was, when we talked about in vaccine lecture about T helper cells, what were the big things about T helper cells? Why are they important? They activate B cells to produce antibodies, but kind of what's their big overall role?
Memory cells.
Say it again.
Memory cells.
Memory cells, okay, so they can ramp up a response if the immune system is seen. They are the orchestrators. They are linchpins. You knock them out, you see what happens. Okay. So the effects on T helper cells and restoring them is extremely important. And that's why it's such a deadly disease. Okay, so let's just to review. When did you saw her the first of the week, right? Well, let's kind of look at this, then we'll come back. So HIV entry, these are important kind of things to visualize because this is where the drugs go. Okay? So you've got the docking or the virus attaching to like a T helper cell, and then it requires about 3 different receptors to do that. So we have a drug against each one of those parts of that receptor. We'll talk about those. Fusion, so there's fusion inhibitors, there's CD4 antagonists that are out there. The co-receptor CCR5 antagonist is another common, very common one, and we have drugs against all of those. So we can do a pretty good job of keeping the virus out. Then once it fuses and it gets in, it takes over the machinery just like any virus, right? Okay. So it takes and inserts its ability to replicate inserts it in. So we can stop it at many different parts. You talked about the NRTI, so any type of transcription, 2 different types we can interfere with. So we can interfere with enzymes within that process, so like the proteases, the integrases, right, the transcriptases, all of those are where those drugs are doing. And then we have boosters. We talked about this in Hep C. We talked about using ritonavir as a pharmacologic booster. What did it do? Why did we use it? What's ritonavir do?
Did it augment the effect of the other?
It augments, how does it do that? If it's a pharmacologic booster, what is it doing? This is the one time when we use a drug interaction in our favor. And what do we do? What's the biggest cytochrome P450 system I have talked to you about? 3A4. It's a 3A4 inhibitor. Drugs that are metabolized by that system are now not metabolized. So what happens? The amount goes up and the duration is longer. Okay, so that's one of the drugs we can use. So we have boosters that we can add to, and some drugs require a booster. to be added to them. Okay, so let's look at this video.
Targeting HIV replication. The replication of HIV-1 is a multi-stage process. Each step is crucial to successful replication and is therefore a potential target of antiretroviral drugs. Step 1 is the infection of a suitable host cell.
Okay, let's look at our projections.
Which ones? These ones?
The green ones.
Green?
It's a
You
figure.
never know what's going to pop up after your video. Okay, I'll have to, I wonder if it works so well. Okay.
Targeting HIV replication. The replication of HIV-1 is a multi-stage process. Each step is crucial to successful replication and is therefore a potential target of antiretroviral drugs. Step 1 is the infection of a suitable host cell, such as a CD4 positive T lymphocyte. Entry of HIV into the cell requires the presence of certain receptors on the cell surface. CD4 receptors and co-receptors such as CCR5 or CXCR4. These receptors interact with protein complexes, which are embedded in the viral envelope. These complexes are composed of two glycoproteins, an extracellular GP120 and a transmembrane GP41. When HIV approaches a target cell, GP120 binds to the CD4 receptors. This process is termed attachment. It promotes further binding to a co-receptor. Co-receptor binding results in a conformational change in GP120. This allows GP41 to unfold and insert its hydrophobic terminus into the cell membrane. GP41 then folds back on itself. This draws the virus towards the cell and facilitates the fusion of their membranes. The viral nucleocapsid enters the host cell and breaks open, releasing 2 viral RNA strands and 3 essential replication enzymes: integrase, protease, and reverse transcriptase. Reverse transcriptase begins the reverse transcription of viral RNA. It has 2 catalytic domains: the ribonuclease H active site and the polymerase active site. Here, single-stranded viral RNA is transcribed into an RNA-DNA double helix. Ribonuclease H breaks down the RNA. The polymerase then completes the remaining DNA strand to form a DNA double helix. Now, integrase goes into action. It cleaves a dinucleotide from each 3' end of the DNA, creating 2 sticky ends. Integrase then transfers the DNA into the cell nucleus and facilitates its integration into the host cell genome. The host cell genome now contains the genetic information of HIV. Activation of the cell induces transcription of proviral DNA into messenger RNA. The viral messenger RNA migrates into the cytoplasm, where building blocks for a new virus are synthesized. Some of them have to be processed by the viral protease. Protease cleaves longer proteins into smaller core proteins. This step is crucial to create an infectious virus. 2 viral RNA strands and the replication enzymes then come together and core proteins assemble around them, forming the capsid. This immature viral particle leaves the cell, acquiring a new envelope of host and viral proteins. The virus matures and becomes ready to infect other cells. HIV replicates billions of times per day, destroying the host's immune cells and eventually causing disease progression. Drugs which interfere with the key steps of viral replication can stop this fatal process. Entry into the host cell can be blocked by fusion inhibitors, for example. Inhibition of reverse transcriptase by nucleoside inhibitors or by non-nucleoside reverse transcriptase inhibitors is part of standard antiretroviral regimens. The action of integrase can be blocked. Protease inhibitors are also part of standard antiretroviral therapy. Each blocked step in viral replication is a step towards better control of HIV disease.
Okay, we're going to come back and visit each of those as we go through. Virus is weird. I mean, there's nothing they do except infect and replicate and move on. There's no self-actualization. They never heard of Maslow's, I mean, there's nothing. I mean, what do they live for? To see their progeny? I just think it's odd that it's just that they have evolved, that's what they have become. Anyway. Okay, so goals of therapy. So what are we trying to do when we use antiretrovirals? Well, one is we want to reduce the morbidity and mortality. So keep them from getting opportunistic diseases, which are what? What are the kinds of illnesses they get?
Pneumonia.
Okay, fungal and candidiasis, systemic, what else?
Cancers.
Cancers, what else?
Pneumonia.
Pneumonias. A lot of those atypical pneumonias are theirs. What else? CMV, so cytomegalovirus. Something to say the other? What is MAC? Okay. And TB, very common. Hep C, Hep B usually are activated because, especially when you treat them. Did y'all talk about iris? Okay, good. Let's see. So we want to prevent transmission. We want to maximally suppress the virus. Okay, so that's where we measure the viral load. We want it below detection. And we also want to keep them from drug-resistant mutations because that just renders our drugs useless after a time. Who do we treat? We treat everybody. Anybody who's got HIV infection, we treat because eventually they will progress. They may not progress to AIDS, but they will progress over time. So here are the type of ARVs. 30 antiretrovirals are on the market right now. We're going to look at examples in each class, not all of them, but mechanistically what they do, and then what their role is and kind of where they sit. So the nucleoside or nucleotide reverse transcriptase inhibitors are your foundation. So like Kristen said, 2 of them in every pot. Okay, so that's where we start foundationally. And then we add a third. So the NNRTIs, or the non-nucleoside reverse transcriptase inhibitors, are an option. So are the protease inhibitors, the integrase inhibitors. Those are mostly your enzyme inhibitors. So one of them. The integrase inhibitors are usually the preferred. They're very well tolerated, and they tend to have a high resistance to genetic change, so they're usually preferred. Then you have your viral entry inhibitors. So there's your fusion inhibitor, your CCR5, and your CD4 post-attachment inhibitors. That's all that receptor complex they were showing you at the beginning of that video. And then you have your boosters or enhancers. So you have ritonavir and you have cobicistat, which is similar in structure to ritonavir. Okay. So where to start? So you all have already covered this. So this is looking at a naive, treatment naive. So people who've been exposed to a treatment have a different, there may be a different approach for them. So you've got your NRTIs, or your nucleoside reverse transcriptase inhibitors, and there's 3 combinations that are fairly common. So you have abacavir or lamivudine, so ABC or 3TC. Or you have tenofovir. Tenofovir comes as 2 different types of prodrugs. And they're listed there. The tenofovir alafenamide with emtricitabine, so TAF or FTC plus, or tenofovir disoproxil fumarate, TDF, also with emtricitabine. Okay. So those are the most common approaches. Then we combine it with a third drug, just like you have talked about. So we can use an integrase inhibitor, again, usually preferred, non-nucleoside reverse transcriptase inhibitors, or a protease inhibitor, with or without a booster. So when you would see a patient come in, you'd look at their drug regimen for AIDS, and because you've had this class, and I have taught you, you can go, you know what that is? That's an NRTI, that's a protease, that's another NRTI, and there's a booster. Now, if you looked at the regimen and you didn't see a second NRTI, you would ask them, are there any other drugs you take? And they're going, no. And you're like, how come? What? Tell me about why you're not on them. So that's what this should spark. You should have some basic concept of what the construct of the AIDS or their HIV regimen is, and then ask questions if you see them missing. Okay? All right. That's what I would expect. I would expect on a test that I could give you a regimen, and you could tell me that is the NNTR, or a protease inhibitor, or the booster. Okay? Just big names, the names we go through, and link them to a class. Okay? The choice of that third drug is going to be multifactorial. So one is going to be resistance. What's the likelihood that that patient's going to be resistant? So we've also got 2 different types of HIV viruses, right? We got HIV-1, HIV-2. Which one is most common in this country? 1. Who is likely to have HIV-2? It's like less than 0.5% of the population. West Africa. So if you have somebody from West Africa, they are more likely to have HIV-2. In Africa, most common. It's a different type of disease. Slower onset, kind of a little bit less pathogenic. So keep that in mind. But some of our drugs will hit both of them. Some of them will hit only one. All of them that we use hit HIV-1. The barrier to resistance, efficacy, adverse effect profile, mostly where we get looking at, is your liver working, your kidneys working, what's your psych history? So some of these drugs are mood changers, cause depression, or psychiatric symptoms. The other big one is hypersensitivity reactions. So some drugs we have to test before we use. Remember some other drugs that we had to test for certain genotypes? Can you think of any? Pardon? Okay, dapsone in terms of G6PD. But what about like allopurinol? Remember we had to look at certain alleles because you could have terrible hypersensitivity reaction. Some of the anti-seizure medicines. Okay, so there are drugs that we also do that before we use them to make sure they don't have that allele, because if they do, they're likely to have a fatal hypersensitivity reaction. So most of these drugs carry some degree of hypersensitivity. What are their other comorbidities? I've kind of talked about that. Convenience. So because you're taking usually 3 or 4 drugs, pill burden becomes a problem, or multiple regimen or administration times. Okay, so this should just be old news to you. Okay, so the more complex the regimen, the more likely they're not going to be adherent. Okay, so you got to match it up with the person. You may have somebody who's really OCD and they're going to take it exactly like you want them to take it. And then you're going to have other people who are going to have no clue as to why that's important. So one of your jobs is always to bring it home is that adherence and your ability to control this virus is linked more than almost any other drug we've ever talked about. In drug interactions. For the most part, most of these don't have a lot. Some classes have none, and that's why they sit where they do. In others, that 3A4 usually is one of the primary pathways that we're going to be concerned about. So just like anything, if you are adding a drug to a regimen, an HIV regimen, you have always got to look at it. Or if you're taking it away. So any change, adds, subtracts, needs to be looked at. Okay, so we talked about that. So did she talk about the guidelines for antiretrovirals in adults and pediatrics? I didn't get it posted, but I will. They come out about this time of the year. This is a good time always to teach this class because they put out new guidelines every year. And there is a great website that I will send you. It's AIDS Info, and they post all the guidelines, and they have guidelines for everything. But they just posted their treatment guidelines, so I updated the handout based on that, and I will send you the link. They also have great patient handouts. Their explanation of drugs is beautiful. Whoever did it knows what they're doing because it's scientifically very sound, but it's put into words that people can understand. So it's a really good place to go and look, and they've got pictures of all the drugs, so it's a really good resource. So I will send you that link. Pregnancy testing needs to be done on any woman who is being started on a drug, especially those who, in addition, those who do not practice or who don't use an effective birth control method. Some of the drugs can cause neural tube defects and should not be used in the first trimester. So we'll point those out as we go along. Okay. Questions about these? Okay, let's go through each of the classes then. For the NRTIs, also referred to as nukes, I'm not going to call them that, but a lot of your patients may. These are drugs that look like nucleoside or nucleotides. What are nucleotides? What are they?
DNA.
I must really get old. I cannot hear or understand anything you're saying. What makes up DNA? Nucleotides and a sugar, right, and a connecting to go down 3 little molecules. Okay, so in DNA, what are those? Adenine,
guanine, cytosine, thymine.
So when we say that they are analogs, they look like it. Remember in the picture it showed you that the cell is starting to take the messenger RNA, there's the recipe, and converting it over to DNA? Okay, so that's what these drugs are. They look like adenosine, cytosine, or guanosine, and they are going to be inserted into that chain and they're going to stop termination. That's why they're so effective, okay, when they're inside the cell. Okay, so here are 5 common ones: abacavir, tenofovir, disoproxil, alafenamide. Again, those are prodrugs. Lamivudine and triacetylene. Those 2 are considered to be interchangeable. You never use them together. You never use 2 tenofovirs together. So usually you're going to see abacavir with one of the tenofovirs, and then the other 2 at the bottom with one of the others on top. Okay, so mechanism. Let's go back over that. I think this one's short. Will you open for me?
You get to exit out of the.
I know, I can't, but see the little things, this is what they call it. There we go.
During infection by HIV, 3 enzymes play essential roles in the life cycle of the virus: reverse transcriptase, integrase, and protease. The first enzyme, HIV reverse transcriptase, copies the viral RNA genome by combining individual host nucleotides to build a complementary DNA strand. When reverse transcriptase finishes this strand, it will replace the original viral RNA with another DNA strand, forming a DNA double helix. The second enzyme, HIV integrase, inserts the viral DNA into the cell's DNA. The third enzyme, HIV protease, is needed at the last steps of the viral life cycle to cut the HIV polyprotein into its individual functional parts. HIV enzymes are targets for drug therapy. 2 types of drugs block reverse transcriptase.
These are all drugs.
Drugs like AZT mimic the normal building blocks of DNA, but prematurely terminate the DNA chain. Drugs like nevirapine bind on the backside of reverse transcriptase, distorting the enzyme so that it can no longer perform its DNA-building reaction. Raltegravir binds to 2 magnesium ions in integrase that are essential for the DNA integration reaction. Drugs like seguinavir mimic the proteins cut by HIV protease, blocking maturation of the virus. Drug resistance is a major problem for HIV drug therapy. For instance, when patients are treated with drugs that block HIV protease, most of the viruses are destroyed, but rare mutant forms of the virus survive. These mutant viruses make a mutated form of the protease. this protease resists the binding of drugs, but can still cut the viral polyprotein. Over many generations, the population of viruses builds up additional mutations that further resist the drug. The most effective current treatment method uses a combination of drugs that attack the different enzymes, so that some of the drugs will still be active even if one of the enzymes becomes resistant.
Okay, so you know why they use 2 of the NRTIs. Okay. Okay, so these affect both the HIV-1 and HIV-2. They have lots of side effects with them. So most of them are linked to what they do to the mitochondria of our cells. So they're common ones, and there's lots of them, is peripheral neuropathies, pancreatitis, lipid disorders, very common with a lot of the drugs that we use for HIV, liver impairment as well. All of these drugs have big black box about lactic acidosis. It is a very, it's lethal. 1/3 or more of patients die, but it's low occurrence. It's kind of, I split that sentence funny, but so the black box warning, serious but rare. So you can think of it that way. Drug interactions, very few, except for tenofovir and rapamycin. So think TB. Anytime you see like rifampin, rapamycin, they always have lots of drug interactions associated with them. So that's about all you see with that class. So that's good. That's another reason why they're used, is because they are usually fairly well tolerated. Even the side effects that occur can be serious, but they're rare. And then low in drug interactions. Okay, tenofovir, it is a nucleotide analog of adenosine. Okay, so there's your nucleotide. Prodrugs, remember that both of them are prodrugs. Let's see. So TDF is almost always, you see it with emtricitabine. Think about it when you do TDF, it's kidney, lots of different kidney problems, bone loss. With TAF, it is usually better tolerated. It's the newer of the two. Better tolerated, fewer side effects, less renal, less bone toxicity. But usually they'll use it with a boosting agent. So you may see it with that cabecistat or ritonavir. So one of the reasons, and that is supposed to be due to the fact that they can use lower doses. Even though you get increased bioavailability and plasma concentration, that doesn't really make sense to me, but it's usually better tolerated. Abacavir, probably one of the big standards. It's a guanosine nucleoside. Now here is, on that third bullet, this is the one you have to do the testing on. So be sure you star that and know that. This is the HLA-B5701. If they test positive for that, then you're not going to use it because of hypersensitivity. And I gave you the information to remind you, okay, we've seen this before with other drugs. Now, like with allopurinol, it was mostly Asian descent, mostly Chinese, okay? This one doesn't carry that. We've seen that with others where it may be Asians, Koreans, but it was subgroups. So we didn't test everybody. But here, you would test everyone. It doesn't have an ethnic relation. The hypersensitivity reactions are very significant, and so patients are taught about these 5 different types of symptoms, and they're told that if they have 2 or more of those, they need to see someone right away. So fever would be one. Another would be just an overall bad feeling, malaise, I just don't feel good. You've had that when you have a virus. A lot of times you have just that general, I'm not sick, but I just don't feel good. Okay, so it's that. GI, so nausea, vomiting, diarrhea, abdominal pain, fairly non-specific, but that's where they're telling you to couple it with something else. You feel really bad and you've got these GI complaints, call the doctor. Respiratory symptoms, dyspnea, cough, sore throat. A lot of these drugs put these patients at higher risk for severe pneumonias. And then that rash, so hypersensitivity hallmark. Okay. So here the drug has to be discontinued and the patient moved to something else. This is one of the more odd drugs where coronary artery disease is an adverse effect. So I would kind of look at that as that's the one that sticks out. Lamivudine and intracidabine, these are cytosine analogs. They are considered interchangeable. You would never use them together. They really are very well tolerated. You see pancreatitis is a low but serious adverse effect, and then hyperpigmentation of the skin, usually soles and palms of feet. So that kind of type of skin is what gets affected. These are all, I put down there for combination, they're always going to be used in combination, always. You'll see I gave you the individual names for these, but most of the time patients are going to get a single drug or a single pill, but it'll have 3 or 4 different agents in it. So most of the times these are going to be embedded in a 3 or 4 drug pill. So that helps with adherence. But they do come singly as well, and that's why you see that at the top. Okay, let's go through the non-nucleoside and then we'll take a break there. Remember, these agents, yes?
I was just going to ask, so the combined pills, does that require like a special compounding pharmacy, or do you really?
They're commercially made that way. So I've given you 3 to look at. The 3 at the bottom are a little bit older. So there's the etravirine, the efavirenz, and rilpivirine. Just have to get to the mode and thinking how they come about. These are active against HIV-1. They're not active against HIV-2. So your West African patients, you would not use these in. Okay.
HIV-1 is a virus with a high replication rate. Within infected CD4 cells, the viral nucleocapsid breaks open, releasing 2 RNA strands and essential replication enzymes, such as HIV-1 reverse transcriptase. It is a heterodimer with a p51 subunit and a p66 subunit. The p66 subunit contains a finger, a palm, and a thumb region, resembling a cupped hand. Reverse transcriptase has 2 catalytic domains, the ribonuclease H active site and the polymerase active site. Here, single-stranded viral RNA is transcribed into a RNA-DNA double helix. Ribonuclease H breaks down the RNA. The polymerase then completes the remaining DNA strand to form a DNA double helix. This proviral DNA contains the genetic material of HIV-1. Therapeutic suppression of viral replication slows down the decline of CD4 cells and disease progression. Nucleoside reverse transcriptase inhibitors, NRTIs, inhibit the polymerase active site. After metabolism to non-functional nucleotides, their incorporation causes chain termination. The non-nucleoside reverse transcriptase inhibitors, NNRTIs, form another class of powerful antiretroviral agents. They inhibit reverse transcriptase by reducing its conformational flexibility. The thumb region of reverse transcriptase is flexible. It opens and closes like a hand. Only the closed position allows transcription of RNA. The base of the thumb has a hydrophobic, pocket-like binding site. This is the target of NNRTIs. Nevirapine is an important representative of this class. It does not need to be metabolized. In its native form, nevirapine binds in the pocket. This locks the thumb in the open position and prevents the transcription of RNA. Thus, nevirapine stops viral replication. Due to this mechanism, nevirapine is a potent partner in the combination therapy of HIV-1 infection.
Okay, so very different mechanism. So these are always going to be used in combination with the NRTIs, never by themselves, never two of them together with another class. They are long-acting, so this is good in terms of pill burden reduction in a regimen. So the ones we're going to look at are efavirenz, which is Cystiva. Thing to note with this one is that teratogenic effects. I would consider them all teratogenic just to remember. It isn't likely you would be starting them, but keeping that in mind, especially for looking for, are they on effective birth control? That's what would always spark my, and have you had counseling? Because so there are safe regimens that women can take and become pregnant and take during pregnancy. But that really needs counseling and planning for those women. The other that you're going to see repetitive is that this class tends to cause CNS side effects. So you see the vivid dreams, confusion, dizziness, psych, worsening of anxiety, mood disorders, depression. And then there's that hypersensitivity reaction. That's how I would kind of group them. If you look down on the next one, rilpivirine, it's different in that QT interval prolongation, renal function. Now you then start to see the repeat, CNS with the mood changes and then hypersensitivity reaction. This one has more drug interactions. Think TB. I'd always, anytime I see a rapamycin, rifampin, I can't say it enough, I always think drug interactions. They're just too strong of inhibitors of the 3A4. This one requires acid for activation, so you can't use it with a proton pump inhibitor, antacids, or H2 receptor antagonists. The Etraverin, the one at the bottom, is held for people who have a resistant infection. Again, hypersensitivity reactions are the big problem there. Questions about those two? Or do the videos help? Yeah, they're pretty good. All right, let's take a break and we'll come